Good morning, all of you. My topic today is adult orthodontics. The contents include introduction, history, current perspective, increasing interest in the field, classification of adults, difference between an adult and an adolescent, treatment objectives, biomechanical consideration, diagnostic process, treatment plan selection, treatment pathway, types of adult orthodontic treatment, indications, contraindications, biological consideration, retention and post-treatment stability in adults. What is adult orthodontics? According to Ackerman, adult orthodontics is concerned with striking a balance between achieving optimal proximal and occlusal contact of the teeth, acceptable dentofacial aesthetics, normal function, and reasonable stability. History. Kingsley in 1818 indicated an early awareness of orthodontic potential for adult patients. McDowell in 1901 gave the concept of impossible age, that is, above 16 years of age. Lesher in 1912 gave the concept of golden age of treatment, that is, between 6 years to 14 years. Now, what is current perspective? Demographics of American population stated that orthodontists provide services sought by aging baby boomers. What have led to increased interest in this adult interdisciplinary therapy? 1. Did not want orthodontic treatment as children. 2. Parents or they themselves did not know about orthodontics as children. 3. Orthodontist was not available in the vicinity. 4. Dentist did not advise orthodontic treatment when younger. 5. Parents could not afford orthodontic treatment. 6. Incomplete or relaxed orthodontic treatment as children. 7. Gums or periodontal problem because of the malocclusion, concerned about appearance. 9. Can afford orthodontic treatment now. 10. Malocclusion like spacing, crowding becoming more prominent with age. 11. Advised by prosthodontist prior to fixed replacement of teeth. 12. Advised by periodontist to prevent further deterioration of periodontal condition. 13. TMJ problem arising due to malocclusion. 14. Overall heightened concern about dental health. Who are adults? For all practical purposes, an adult is defined as a person who has ceased to grow. Biologically, this happens at around 18 years of age. Adults are classified into 3 groups. Group 1 consists of patients from the age of 18 to 25 years, Group 2 from the age of 26 to 35 years, and Group 3 consists of patients of the age group 36 years and older. Now, in Group 1, the complications that presents are exhibiting heightened concern for aesthetic, but otherwise they are periodontally fine. Group 2 patients, they have more periodontal and restorative problems, and Group 3 patients present prosthodontic complication and may lack a full complement of teeth. Adults and adolescents can be classified into various categories based on the characteristics such as the growth potential. Adolescent patients, we can see the growth modification is possible, whereas in adult patient, no growth is possible. TMJ adaptability. TMJ is adaptable in adolescent patient, whereas in adult patient, it shows frequent signs of TMJ dysfunction. Periodontal conditions are worsened in adult patient, whereas there is rarely any symptoms seen in the adolescent patient. When the general health is concerned, rarely a consideration is seen in an adolescent patient, whereas adult patient might have major concern, especially if surgery is planned. Appliance aesthetic is a major concern to the adult patient, whereas adolescent, they are rarely concerned about it. Retention planning. The adolescent patients require short-term retention, but the adult patient requires long-term therapy. Adolescent patients can be treated by removable appliance, but the adult patients usually require fixed appliances. Appliance tolerance. Adolescent patients are usually well tolerated, but the adult patients require more time to get accustomed to the appliance. Speech. Adolescent patient adjusts quickly, but the adult patient requires time and effort. Motivation and cooperation ranges from poor to excellent in adolescent patients, whereas in cases of adult patient it is usually good. Treatment appreciation. Adult patients are usually very appreciative, whereas the adolescent patient ranges from hardly concerned to very appreciative. Treatment objectives. 1. Parallelism of abutment teeth. 2. Most favorable distribution of teeth. 3. Redistribution of occlusal and incisal forces. 4. Adequate embrasure space and proper root positioning. 5. Acceptable occlusal plane and potential for incisal guidance at satisfactory vertical dimension. 6. Adequate occlusal landmark relationships. 7. Better lip competency and support. 8. Improved crown and root ratio. 9. Improvement or self-correction of mucogingival and osseous defect. 10. Improved self-maintenance of periodontal health. 11. Aesthetic and functional improvement. 12. Best outcome with least risk, usually minimal invasive approach. Parallelism of abutment teeth. The abutment teeth must be placed parallel with the other teeth to permit insertion of multiple unit replacements and allow for restoration that involve both the anterior and posterior teeth. Parallel teeth does not require excess cutting or devitalization during abutment preparation and allow for a better periodontal response. Parallel abutments allow for better restorative retention and help prevent cement washout and caries. Most favorable distribution of teeth. The teeth should be distributed evenly for replacement of fixed and removable prosthesis in the individual arches. They should be positioned so that the occlusion of natural teeth can be established bilaterally between arches. Redistribution of occlusal and incisal forces. Cases with significant bone loss require that the occlusal forces be directed vertically along or on the long axis of the roots to maintain the occlusal vertical dimension. When the posterior teeth are missing, the anterior teeth can be positioned to allow for more axially directed transfer of force and can then be reshaped to function as posterior teeth, supporting the vertical dimensions. Adequate embrasure space and proper root position. This allows for better periodontal health, especially when the placement of restoration is necessary. The anatomic relation of the root is important in the pathogenesis of periodontal disease, interproximal cleaning, and the placement of restorative material. Acceptable occlusal plane and potential for incisal guidance at satisfactory vertical dimension. To establish the acceptable occlusal plane for a mutilated dentition exhibiting bite collapse, the Hawley bite plane is inserted with the platform of the anterior plane adjusted at right angle to the long axis of lower incisors. This allows a centric relation at an acceptable vertical relation. If the vertical dimension is excessive, the patient will whistle involuntarily and complain of muscle fatigue in the morning, or the acrylic will develop etched lines or wear streaks. When properly adjusted at correct vertical height, the bite plane will allow simultaneous bilateral neuromuscular activity. No contact should occur between the posterior teeth during excursive movement, and no interferences occurs between anterior teeth while the bite plane is in place. The curve of speech should be mild to flat bilaterally. In supraerupted molars, the most extruded posterior segment will be the ruling factor in determining the potential for an orthodontic solution at an acceptable vertical. Adult molars with amalgam restoration and normal pulpal recession and mixed constrictions often can be occlusally reduced 2 to 4 mm and still allow for placement of restoration without the need for revitalization. Adequate occlusal landmark relationships. The transverse dimension is the most difficult to correct and maintain orthodontically, the sagittal next and the vertical least. Posterior crossbite involving surgery should be positioned so that the maxillary buccal cusp contacts the lower central fossa with the crossover for incisal guidance in the premolar area or the canine position. Better lip competency and support. Many adults have long upper lips that preclude significant maxillary retraction. In cases requiring anterior restoration, retraction is recommended to achieve lip competency while maintaining lip support. Inadequate support may create a change of anterior, posterior, and vertical position of the upper lip and increase wrinkling. This often makes the face seem prematurely aged and is a major aesthetic concern of adults, especially women. Improved crown-root ratio. In adult patients who have lost bone on individual teeth, the length of clinical crown can be reduced with a high-speed handpiece as the tooth is erupted orthodontically. The ratio of crown to root will be improved. Improvement or self-correction of mucogingival and osseous defects. Proper repositioning of prominent teeth in the arch will improve gingival topography. In adults, the goal should be to level the crestal bone between adjacent cemento-enamel junction. During leveling stages, any teeth that have erupted above the occlusal plane should be grossly reduced occlusally. Improved self-maintenance of periodontal health. Improved self-maintenance of periodontal health occurs with proper tooth position. Proper tooth position and improper tooth preparation before irreversible restorative dentistry are causative factors that may contribute to periodontal disease. For better periodontal health, on an individual pattern basis, these teeth should be positioned properly over the basal bone support. Aesthetic and functional improvement. A plan should provide for acceptable dentofacial aesthetics and allow for improved muscle function, normal speech, and masticatory improvements. This is possible when an occlusion is provided that enables the anterior teeth to function as disarticulators and the posterior teeth to support the vertical dimension. Best outcome with least risk using minimally invasive approach. Certain borderline skeletal situations can benefit from judicious therapeutic diagnosis that allows the providers and the patient to achieve a result equal to the outcome if jaw surgery were part of the treatment plan. Biomechanical consideration. The biomechanical system should be chosen according to the type and direction of the tooth movement. 4 methods of differentiation between the effect of forces on the active unit, that is, the teeth to be moved, and the reactive unit, the teeth serving as anchorage, can be proposed as follows. An anchorage unit that consists of a greater number of teeth than the active unit, that is, the teeth to be moved. An anchorage unit where the teeth are united with maximum rigidity. Variation in the movement to force ratio so that the active unit is moved by apical tipping and the reactive by root movement or translation. Adjustment of force system so that the force applied to the anchorage unit can be neutralized by the occlusal forces. Control of anchorage requires that anchor teeth should not be allowed to tip. Fixed appliance is necessary. Adult patients demand for removable appliance, but they are not useful in adjunctive treatment. But in case of multiple missing teeth, removable appliance is useful. In case of reduced periodontal support and bone loss, lighter forces and relatively larger movements are needed. Diagnostic process. Problem-oriented dental record aids in making the appropriate diagnosis, for it requires that the patient's problem be listed and a plan be developed to manage each problem. Diagnostic step includes 1. Collect data accurately. 2. Analyze database. 3. Develop the problem list. 4. Prepare tentative treatment plan. 5. Interact with those who are involved. Discuss plan and options. Clarify sequence. Acquire patient's acceptance. 6. Create final treatment plan. Before starting the treatment, the orthodontist needs to be prepared to do the following. 1. Diagnose the different stages of pedial disease and the associated risk factors. 2. Diagnose TMJ dysfunction before, during, or after tooth movement. 3. Determine which cases require surgical management and which ones require incisor reangulation to camouflage the skeletal base discrepancy. 4. Work cooperatively with the team of other specialists to give the patient the best outcome. Treatment plan selection. Factors affecting the treatment plan selection. 1. Existing oral pathologies. It includes dental caries, periodontal disease, faulty restoration, TNJ adaptability, occlusal awareness. 2. Skeletal relationship. 3. Biological considerations, which includes neuromuscular maturity or adaptability, periodontal susceptibility, that is bone loss or gingival inflammation, rate of tooth movement, growth. 4th point includes therapeutic approaches available, that is functional appliances, orthodontic surgery, restorative dentistry. 5 is extraction therapy, that is 4 premolars or asymmetric, including the lower incisors. 6. Anchorage requirement, which is the headgear or completely erupted first and second molars. 7. Missing teeth, that is space closure without or with prosthesis. Treatment pathway for adult patients. The treatment pathway for adults include interviewing and taking history, clinical examination and general assessment of the patient, analysis of the diagnosis records given by the dental teams. After the data is collected, the diagnosis is made, and if any active pathology is found, that is the caries or periodontal disease, TMJ disorder, or any other active pathology is strategically modified, then the orthodontic review is given, then a plan is made and general treatment plan is made, prioritizing the problem, identifying the optimal solution, and the treatment plan sequence and details for the provider and the patients are given. Types of adult orthodontic treatment. Prophet has classified adult orthodontic treatment procedure as 1. Comprehensive orthodontic treatment, adjunctive orthodontic treatment, and lastly the surgical orthodontic treatment. Comprehensive orthodontic treatment is similar to the treatment undertaken in adolescent and is most frequently undertaken in the group 1 patients. It involves full-fledged treatment with or without extraction of teeth. The treatment objective of comprehensive orthodontic treatment for adults are dentofacial aesthetics, stomatognatic function, and stability. The approach are referred to the orthodontist for malocclusion, that is inflicting them, and not because of any pre-prosthetic or periodontal treatment that may be required. According to Prophet, comprehensive orthodontic treatment would last for a duration of more than 6 months. Fixed appliance therapy may last from 1 to 1.5 years. Comprehensive treatment may or may not combine with the surgical orthodontic treatment. Adjunctive orthodontic treatment. Tooth movement carried out to facilitate other dental procedures necessary to control diseases and restore function. These are procedures which are done as precursor or in conjunction with other dental procedures. These are generally done to facilitate further prosthodontic or periodontal rehabilitation of the patient. These are the most commonly undertaken procedures in the patient who fall in the group 2, that is 26 to 35 years of age, and group 3, that is patients above 36 years of age. The goals of adjunctive orthodontic treatment includes 1. Parallelism and or denotation of abutment teeth, elimination of crowding, elimination of anterior spacing which might be causing frequent food lodgement or aesthetic problems, establishing a more favorable distribution of teeth that can be inter-arch or intra-arch to facilitate prosthetic rehabilitation, establishing a more favorable crown-to-root ratios and or intrusion of specific teeth. Procedures carried out in adjunctive treatment. 1. Uprighting the posterior tooth. 2. Forced eruption. 3. Alignment of anterior teeth. 4. Crossbite correction. All the above mentioned treatments may or may not require the placement of full jaw orthodontic appliances. Most of these procedures can be accomplished by using segmental treatment. The appliance is limited to only a portion of the dental arch and does not alter the occlusion. The treatment duration is less as compared to the comprehensive treatment plan. Surgical orthodontic treatment. After the cessation of growth, the only way to correct true skeletal malocclusion has to involve surgery. Three procedures are involved in sequence: pre-surgical orthodontics, orthognathic surgery proper, and post-surgical orthodontics. Pre-surgical orthodontics helps in achieving a proper alignment and leveling of the arches individually. Orthognathic surgical procedures are used to establish a proper skeletal relationship. This involves the planned skeletal fracturing of individual skeletal bones, that is maxilla, mandible, etc., and the repositioning with the help of bone plates or wiring as required. Jaw achieves proper interdigitations and final position of teeth for balance, stability, and aesthetics. Jaw discrepancy in all three planes of space can be corrected. Post-surgical orthodontics then helps to achieve a proper interdigitation and final position of the teeth for balance, stability, and aesthetics. Indications. Indications for orthodontic treatment can be broadly classified into four categories: prosthodontic, periodontal, temporomandibular joint, and aesthetics. Contraindications. The buzzword is "don't overdo it," which means that do not try it if you think it is not possible. The situation may arise because use of four main reasons: 1. Medical, 2. Periodontal conditions, 3. Skeletal malocclusion, 4. Motivation of the patient. Medical. The patient is medically compromised to an extent that bone formation itself is likely to be compromised. Especially in diseases like diabetes mellitus, the healing capacity of the tissue is much below normal and treatment should be avoided. Periodontal condition of the patient is poor with multiple mobile teeth. Patients who do not maintain good oral hygiene are poor candidates for orthodontic treatment. Skeletal malocclusion, which requires surgical intervention, also might not be undertaken because of the extent of medical and physical condition of the patient. Motivation of the patient. It is advised not to proceed with the treatment unless the patient is found to be determined to see the therapy through to completion. Biological consideration. Changes in the tooth structure, occlusal facets, dental caries, restoration failure. Changes in the alveolar bone, missing teeth, TMJ. Occlusal facets. These are more common in adults as compared to adolescents. These might cause resistance to movement as the teeth tend to interdigitate better and more perfectly. Dental caries. Adults are more susceptible to recurrent dental caries, and these might increase the chances of tooth being root canal treated. Root canal treated teeth might show more root resorption as compared to the normal healthy teeth. Restorative failures. Improper contours leading to the loss of proper contacts. Proximal overhangs causing formation of periodontal pockets. Deficient occlusal carving may cause loss of occlusal contacts, decreasing the chewing capability of the patient. Teeth restored with ceramic crowns or laminates may also pose problems while bonding of the orthodontic attachments. Changes in the alveolar bone. As the age advances, the periodontium is weakened and its reparative capacity is reduced. Decrease in the alveolar bone height of teeth tends to decrease periodontal support. Forces have to be accordingly decreased to move such compromised teeth. This causes a change in the center of resistance, which shifts more apically. The magnitude of the force has to be decreased and bracket placements might have to be altered. As age progresses, the overall rate at which cells are produced decreases, and this in turn might lead to decrease in the rate at which adult teeth move and stabilize. The more slowly the bone forms, the longer and more critical the retentive phase becomes. Missing teeth. Premature loss of teeth might cause, if replaced in time, presence of removal of fixed prosthesis in the patient's mouth. If not replaced within a reasonable period of time, it can cause supra-eruption of the tooth in opposing arch or tipping of the tooth distal to the extraction site. This often leads to narrowing of the bone at the site of extraction. Moving a teeth into such a site is usually difficult and might lead to loss of attachment and mobility. Temporomandibular joint. In adults, the joint should be evaluated not only while diagnosing the case but also monitored during and after treatment. Retention and post-treatment stability in adults. Retention should include maintenance of tooth position and overall dental and periodontal status. Retention can thus be divided into biological and mechanical retention. Biological retention includes the measures necessary in order to maintain an optimal periodontal support. This can only be ensured through optimal hygiene, regular periodontal control, and an occlusion that transfer occlusion forces in a vector passing as close to the center of resistance of tooth as possible in order to avoid occlusal trauma. Mechanical retention must be planned with due consideration of the biological retention. Two types of mechanical retention have been used, fixed and removable. Both can be used for short or long period and even permanently. Retention. Removable appliances and retainers includes the Holly retainer, tooth positioner, spring retainer. Others that are available for retention are fixed retainers, bonded retainers, banded retainers. Thank you.